Hello, I'm Keith Esrick. I'm with the Cure Starts Now and the DIPG DMG Collaborative, and we have the pleasure of speaking with Dr. Maria Tsoli with regard to a study that goes back to 2015, Fenretinide, and the discussion of this as a novel therapeutic agent against DIPG. So I know you have some updates and some findings to present on this, so I'll go ahead and turn it over to you.
Thank you, Keith. Good day to everyone, and I'm really happy to be presenting our preclinical studies on Fenretinide, which was supported by the DIPG Collaborative and the Cure Starts Now. So I think we all sort of understand how devastating DIPG is. So I'm not going to give you an overview on that. But a few years back, we actually decided to take what we call kind of an unbiased approach in finding treatments for DIPG. So we performed a high throughput screen consisting of 3,500 FDA-approved drugs or drugs under clinical development. And we found that from our high throughput screen, there were about 90 drugs for which DIPG cells exhibited less than 10% viability. And out of those 30 drugs, and out of those 90, 30 drugs actually were found from the literature to cross the blood-brain barrier, which is really important in treating DIPG. And one of these drugs was actually Fenretinide, and we have actually also published some other drugs from this high throughput screen recently in the literature. Fenretinide is, it's an interesting compound. It's actually an agent which has been used in the past as a chemopreventative for breast cancer, but there have actually been a couple of clinical trials for using it, such as in neuroblastoma. And overall, they actually have found that it's quite well tolerated in adult and pediatric patients, and it can cross actually the blood-brain barrier, which is really important for brain tumor patients. Another interesting thing was that it was found that it doesn't actually cause any mutations. So therefore, these are actually properties which make it really positive in actually using this particular agent for as an anti-cancer treatment, and specifically for pediatric patients. We were actually interested to find out whether it was just Fenretinide or if it was actually other retinoid drugs as well, which is similar to Fenretinide that actually are cytotoxic in the DIPG cells. And what was interesting, what you see on the left-hand side, is that it was specifically Fenretinide comparing to other retinoid drugs that seem to be cytotoxic in the DIPG cells. And we found over a panel of DIPG cells that Fenretinide was really active against them. Then we actually did what we call a preclinical efficacy study using a DIPG orthotopic model. We actually used a Fenretinide formulation called Fenretinide Lead Absorb that's in collaboration with our collaborators overseas in the US. We found with this formulation that we were able to enhance the survival of the DIPG in this DIPG preclinical model. But overall, we actually found that it was very well tolerated from what you can actually see from the stable weights for which the animals maintained during the whole treatment. What I would like to also say is that this formulation was actually provided orally. Now, Fenretinide has a very diverse ways of acting against the tumor cells. And some of these mechanisms have been described in the literature. For example, it can increase ceramide species. One of its canonical pathways has been inhibiting the retinoid acid receptor. It has also been found to produce reactive oxygen species in the mitochondria. And then all these pathways can actually subsequently lead to cell death. So we decided to look for some of these pathways. And very similarly to what has been described in the literature, we found that Fenretinide did actually cause oxidative stress in the DIPG cells. And what you can see here is Fenretinide causing in a time-dependent way oxidative species. But we also found that it also caused apoptosis, which what you can see, but the induction of caspases 3, 7, 8, 9. And we also saw an increased caspases, cleft caspase, and also cleft PARP, which are the typical apoptotic markers in a time-dependent way as well. So far, good. So that kind of indicates that according to the literature, Fenretinide, it does seem to affect the mitochondria, and it does cause cell death in DIPG cells. However, we knew at the time that there were a couple of reports that had described that fenretinide might also affect kinases. And what is interesting about the kinases is that specifically the receptor tyrosine kinases, they seem to be upregulated in a large proportion in DIPG patients. So we were interested to see whether fenretinide could also affect receptor tyrosine kinases. So what we did was we performed a phosphoprotein array in which you look at the phosphorylation levels of all 49 different receptor tyrosine kinases. And what was really striking for us is that we actually found the phospho-PDGFR, which is a very important target for DIPG, seemed to be significantly reduced. Then we also looked at it in a time-dependent way with Western blotting, and we found that indeed the phosphorylated levels of PDGFR and also PDGFRs seem to be decreased in a time-dependent way, but we also found phospho-PI3K. Now, not only at the phosphor level and at the protein level we saw these decreases, we also saw at the gene level as well that PDGFR was actually decreased. So that was very positive, very interesting news for us. Now, we were interested to see whether fenretinide could actually inhibit PDGFR in a direct way, and we performed the kinase assay. Now, comparing it to ponatinib, which is actually a drug which directly inhibits, it can actually directly bind to PDGFR and inhibit its action. Fenretinide didn't do that. So it seems like from our studies that fenretinide doesn't seem to affect PDGFRA, but it does it in a non-direct manner. Now, given these results in PDGFRA, we were interested to see whether it could actually enhance the survival of a PDX model which has an amplification of PDGFR, which, as I said, is something that can actually be observed in DIPG patients. And we used the same formulation that we used in our previous study, the liumensorb fenretinide, which was orally given. And we actually, quite interesting, found that indeed, in the PDGFR model, which is amplified, we do see a very insignificant enhanced survival. And what was interesting was we actually saw that similarly to our previous studies, we do see an increased number of apoptotic cells, which indicating that DIPG cells are dying, but we also saw a very sort of significant decrease in the PDGFRA levels in these preclinical models. So it does seem that fenretinide does affect PDGFR in the brain, and it also causes apoptosis. Now, apart from this particular formulation, which is the oral formulation for fenretinide, which has been used in neuroblastoma patients before, we've also done in collaboration with other people overseas, with our collaborators in Italy, another formulation, which is actually more a liposomal nanomicelle kind of formulation, in which is given intravenously. So it's given actually through the blood. And we used again the same model as I showed before, which has a PDGFR amplification. So when fenretinide is given intravenously, it actually did increase the survival of this preclinical model significantly. And like before, we did see a very significant downregulation of PDGFR in the brains of these preclinical models. In our conclusions, we actually have found from our studies that fenretinide does actually have a cytotoxic and anti-tumor efficacy in DIPG. Similarly to what has been reported before, it does cause reactive oxygen species and cell death in DIPG. We did identify a very novel mechanism for fenretinide, which is the inhibition of PDGFR, and this is something that we need to understand a little bit more. We did actually find it with our studies that it can actually enhance the survival of PDGFR amplified PDX models, but also in a wild type model using two different formulations. And this is something that we need to understand further because it will actually assist with patient stratification in future clinical trials. However, we do need to do a lot more studies, and particularly we need to find ways to optimize the formulation particularly for pediatric use, and also find potential combinations for future therapies, for future clinical trials. I would just like to finish my presentation by thanking the Brain Tumor Group and our collaborators. Our collaborators, Isabella Rienti and Giovanna Ferrugia, provided the intravenous formulation of fenretinide. Patrick Reynolds was a collaborator who actually provided the limit-sob formulation, which is the oral formulation of fenretinide. Other collaborators who has been helping us along the way with PDX models. And of course, I would like to thank for the support from the DIPG collaborative and the QStats now, and of everyone who's actually involved in supporting these studies. Thank you.
Thank you for talking about that, Dr. Tsoli. I have a couple of questions, if I may.
Sure.
Obviously, you talked about this was being used with neuroblastoma. Is this adult patients, I would assume?
No, this is actually pediatric.
Pediatric, okay.
No, they were children, yes.
Does that give us some of the safety data on the use of this at all? Are we at that point that it can be looked at for applications in
yeah, that's true. That's true, Keith. I mean, it's a good starting point, the fact that there have been some clinical trials being performed, particularly with the oral formulation of fenretinide, the limit-sob. However, my understanding is that with those particular studies that they were actually not able to, although it was found that it was actually well tolerated. I think I believe they did not actually identify the maximum tolerated dose. So we actually don't know up to what point we can actually administer fenretinide in children. So I believe we do need to do more clinical trials, particular phase 1, phase 2 clinical trials for children.
Okay. Is there any known, safety or potential side effects that you already know about in the limited studies?
My understanding is that although it's well tolerated, there has been some issues, particularly with not being able to see well at night. But it's actually reversible. I mean, it's something that it can be. It's not like it's more like a temporary kind of a side effect.
Okay.
So more like night vision issues, yeah.
You talked about some of the different formulations to try to effectively make it more effective there, but have they also looked at the combinational, possibilities of the drug, and are there combinations that make sense at this point, or even steps to look at that in trial settings?
Yes, what I didn't actually present today was some of our combination studies that we've done before. And something that I actually had presented before at the DIPG collaborative meetings was combinations with other PDGFR inhibitors, such as ponatinib, for example, which in our preclinical work, particularly in the cell culture, seemed to be very effective. However, unfortunately, ponatinib is one of those PDGFR inhibitors that doesn't actually cross the blood-brain barrier. So it was actually very difficult to actually get it to work in PDX models. So there is actually potential in, as we're actually getting improved kind of drugs that inhibit PDGFR directly, to perhaps combine it with that. However, for the limit-sob formulation, I have been aware of a clinical study with ketoconazole. Is actually a drug that can actually inhibit the degradation of fenretinide in the liver. So if we actually stop its degradation in the liver, it can actually increase its bioavailability. So that's actually another potential combination that has been used in neuroblastoma. And I'm not sure if the clinical trial is finalized already, but it was in neuroblastoma patients.
Okay. And I noted that one of the things that we had talked about a while back was also CBL-0137, I think. And
yeah.
connection with that, is that still something to be just looked at all, or not?
In combination with fenretinide?
Yes.
Oh, that's a good question. I'm
taking it from your slides from a couple of presentations ago.
Yeah, and I think not particularly, I suppose, for fenretinide. But I think CBL can actually be combined with ACT-001, which is another drug under clinical development at the moment. But with fenretinide, unfortunately, we didn't see any beneficial effect by combining those two together.
Okay. Is this something that you see as having possibility more for a singular treatment, or do you think it just really needs to be in a combinational setting?
Look, ultimately for DIPG, we will always need to combine it with something. I mean, we have to be realistic that, I mean, we do need the data, I mean, definitely as a single agent, right, to understand up to what dose we can give to the patients, you know, and does it actually, can we actually see it penetrate into the brain in obviously brain tumor patients especially. But ultimately, yes, I think combinatorial approach will actually be the best for any kind of brain tumor.
Okay. This is rather, this is good timing, I guess, this update, part of which is because we are also getting questions from parents that are considering this for trying to get access to it for compassionate access, and also see if it can be, you know, available, you know, through other routes. It sounds like, based upon the study that you have here, that we may not know enough to really kind of pursue that. Would you say that that's a good assumption, or is it something that should be considered on a patient by patient basis?
Look, I think it's still a little bit premature to actually be giving it in a compassionate use, although I'm not a clinician. So I think it's just, we need to make sure that we need to give it at a dose which can be obviously well tolerated in children. I mean, my understanding is, particularly for some of the neuroblastoma patients, was actually given in nutritional kind of meals. So it's not like you're going to get, I don't know, 10 pills a day, and these are the, you know, the amount of pills that you need to take. So I think we need to be really careful about how we're going to administer it in children in a dose that obviously is going to be effective. So that's what we need, more phase 1, phase 2 clinical trials for that. Okay. We do really need to know the right patients that we need to give it. I mean, it does, from our preclinical studies, we do seem to have really good effects in those sort of PDX models that have a PDGF amplification, which is a really good starting point, I suppose. But we do actually see effects as well in PDX models that don't have the PDGF amplification. So we really do need to understand what are the right patients to actually give this drug to, so in order to have the best effects. So okay. I will probably say, yeah, just hold on at the moment until we have a bit more information from phase 1, phase 2 clinical trials.
Any updates that are going to be still coming out with regards to this work, and what do you see as the next steps for this?
Yeah, I think at the moment we're just finalizing our manuscript in order to be able to publish the study. So we're more than happy. Yeah, hopefully this will actually be, you know, published soon. But yes, we do. Yeah, we do have a few things in mind in terms of combinatorial kind of approaches. You know, particularly with PDGFR inhibitors. So yeah. Okay, well, keep us posted. But yeah, we do need a little bit more preclinical work.
All right. Well, we look forward to the updates on it. Keep us posted. Obviously, you do absolutely phenomenal work, and thank you. It's been a privilege to try to help in any way we possibly can. So, thank you for helping us with this.
And I thank you for all of your support. I thank the whole DIPG collaborative. So. Thank you for supporting us over the years, and particularly with all of the studies that we have done so far. We greatly appreciate it.